Christine Elliott announced Ontario's first local health team in Mississauga.
Yes.
And the funding for it. It's a new governance structure. It's a beginnings of a new reimbursement funding model. In your heart of hearts, what's new about that model that the old model couldn't deliver?
So the old model was the LHIN, the Local Health Integration Networks. Conceptually, it was a good idea, but the implementation of it was very poor. And what we ended up seeing was the LHIN really was a buffer between the ministry and everything else. And we ended up with a bureaucratic layer that was costing more money than what we were seeing as results in the end. Switching to the Ontario Health Teams model, we're removing that middle tier layer and trying to allocate more of the funds down to the service level. Mm-hmm. There are agreements that are in place then with the different providers within the LHIN, within the Ontario Health Team. And there is a lead organization who effectively is the payer. They would distribute the money back out to the other organizations that are part of it. Really what it has done is it has made it a little bit more nimble, because you can respond more quickly to the geographic needs or the regional needs of your organization. We have more of those organizations, but we've taken out an entire middle layer of administration that won't be there as part of it.
So if you're the patient, how will that affect your navigation and access as you age, as your chronic condition changes over time, or you need emergency services or chronic care services?
So in general terms, and I don't want to get right down into the weeds of it, but in general terms, let's say that you've got an elderly patient who has slipped and fallen, they've gone into the hospital, they can no longer go back home, they should be going to a long-term care facility. Or conversely, you have that same patient who slipped, they fell, they've gone into the hospital, they're ready to go back home. The way that the old system worked was the hospital would then work with the LHIN through the CCAC. Mm-hmm. There would be a layer of bureaucratic levels there. It would take 4 or 5 days for them to make an assessment. Meanwhile, the patient may only need 3 days in the hospital. They're going to stay in the hospital for another day or two longer because of how that bureaucracy went. And it wasn't a sight line from the hospital to the home care, wasn't a sight line from the hospital to the long-term care. It was from the hospital up to the LHIN, from the LHIN down and back and forth. Now it'll be from the hospital directly to the home care provider if you're going back home. The assessment should be done much more quickly, and you should be released back to your home quickly. If you need to go to long-term care, again, the hospital has the sight line directly to the long-term care instead of having to go up one layer, back, and so on.
It always takes 3 people longer to make a decision than 2 people.
So this process should be much quicker, and we should be seeing people at the level of care that they need sooner.
Okay. Bill 116, tangent to that, is on the Mental Health and Addiction Services Act, which is designed to affect the quality and administration of mental health in Ontario. Do you want to comment on that one?
Sure. I actually spoke to that one in the House this past week. I talked specifically about this riding, some of the challenges that we faced, and I'll touch on a couple of them. One of them is the opioid crisis. Bill 116 will help with the opioid crisis. In our area, in the city of Peterborough, this year alone we've had 26 deaths from opioids. 21 of them were people in their own residences. So it's a very different look to the opioid crisis than it was 20 years ago. We know that there are a number of people who are having mental health challenges within our community, and there aren't the services in place for them to do the things that they need to do to get well, or to at least see some form of progress. Bill 116 is one of those tools that we're going to be using then to tighten those things up so that people can get the service that they need when they need it. They don't have to go through as long of a waiting list. The worst case scenario is you have somebody who comes into the hospital with suicidal thoughts and you're referring them to an expert 6 months from now. You want to get them to that expert
quick
right
response
away.
Processes is
Absolutely,
what you're talking about then?
much quicker.
Gets the client and the provider together faster, kind of thing.
And opens the avenues for the funding to flow more appropriately from organization to organization to get money where the service needs to be for the individual who needs that service.
Okay, and what's been the reaction from, let's say, Canadian Mental Health Association? They're positive with this. They see themselves as an expanded provider role or a broker role in that?
We haven't seen any pushback from any of the service providers on this one. Actually, it seems to be very well received on it. Even the opposition party has been very measured in their negative response to it. They have been, for the most part, very positive that it's a good first step.